My dear friends and colleagues, warm welcome to the fifth session of Anesthesia Connect and the fourth magazine edition. Today is a special day for us because we are coming to you live from the venue of AnaesthesiaCONNECT 2025 at Raipur. Even as we participate in the national conference, our commitment to continuous weekly academic engagement remains unchanged. AnaesthesiaCONNECT has become a platform that connects Kerala with the rest of the world every Saturday, and I sincerely thank each of you for your enthusiastic participation. Today's magazine edition brings a collection of carefully curated topics presented in a crisp and engaging format. I invite all of you to stay with us, contribute your thoughts, and make this session vibrant. As always, we will also have our ISA Kerala Kahoot quiz, of course with exciting cash prizes and certificates. I request everyone to join the quiz and make it lively. Thank you for being with us, whether you are from Raipur or from Kerala or from anywhere across the globe. So let's begin today's session.
Welcome to the fourth episode in our Risk Script series. Post-operative outcomes don't have to be a guessing game. We have two practical tools that can help us estimate surgical risk and anticipate complications early: the POSM and the surgical APGAR score. POSM, or the Physiological and Operative Severity Score for the enumeration of mortality and morbidity, combines two things that we already assess every day: physiological variables like the pulse, BP, GCS, etc., and the operative severity like blood loss, contamination, complexity. Now, by blending both these, POSM gives a predicted risk of morbidity and mortality, useful for counseling and resource planning. On the other hand, the SAS, or the surgical APGAR score, is much simpler, just three numbers pulled from the intraoperative period. Together, they are fast, objective, and immediately available as soon as the surgeon closes the skin. Over to Dr. Shruti Estharan, who will look at and discuss post-operative risk scores. Dr. Shruti.
Hi everyone, I am Dr. Shruti Estharan Koshi, Assistant Professor in Department of Anesthesiology, Believers Church Medical College. Let's dive into two essential scoring systems that help us to predict postoperative mortality and morbidity risk in surgical patients. These scores can guide our decision making and optimize patient care. PPOSM, Portsmouth POSM Scoring System. POSM stands for Physiological and Operative Severity Score for the enumeration of mortality and morbidity. What is PPOSM? The definition is PPOSM is a scoring system used to predict mortality and morbidity in surgical patients. PPOSM has 12 physiological and 6 operative variables. These are the parameters for physiological scores, and these are the parameters for operative scores. Here, a case scenario of a 67-year-old male patient posted with right inguinal hernia for mesh hernioplasty is a known case of hypertension on tap telmisartan and is a known case of dyspnea on exertion, COPD on MDI inhaler. On examination, pulse rate is 78 BPM and BP is 140/90. His saturation is 97% at room air and investigations are hemoglobin 13.2, total count 5400, urea, creatine and serum electrolytes are within normal limit. Let's calculate the POSM operative severity score for this case. Here, I am sharing a Medcal QR code that will help you to calculate all sorts of risk score in your daily practice. Here, these are the parameters for operative severity score. The given case, its an operative severity is moderate and the number of procedure is 1. And the total blood loss will be between 100 to 500 ml, and there is no peritoneal soiling, and there is no presence of malignancy, and the mode of surgery is elective. Therefore, the score will be 2 plus 1, 3, plus 2, 5, 6, 7, 8. Therefore, the operative severity score is 8. Let's now review what we have learned for the past few weeks. This case will come under the ASA physical status of ASA2 with mild disease without any functional limitation and the RCRI score of 0.5% risk of major cardiac events and the ARISCAT score of low risk with 1.6% risk of post-op pulmonary complications. And the physiological score of POSM will be 15 points and the operative score, as we have discussed, will be 8 points. How to calculate the POSM score? These are the equations for the POSM for mortality risk and morbidity risk. These are the limitations also because of the complexity of calculation. And the limited applicability in certain patient population like trauma surgeries and pediatric patients. No validation for preoperative risk prediction because of inclusion of intraoperative and postoperative variables. Therefore, the summary is PPOSM is a useful tool for predicting surgical outcomes and identifying high-risk patients. By using PPOSM, clinicians can make more informed decisions and improve patient care. Let's move on to surgical Apgar score. It's a simple tool for predicting postoperative outcomes. What is surgical Apgar score? The surgical Apgar score is a simple objective measure of the condition of a patient after surgery based on 3 easily obtainable parameters. It is developed by Atul Gawande et al. In 2007. The parameters include estimated blood loss, lowest heart rate, lowest mean arterial pressure. These are the scoring, like it has a total score of 0 to 10 points. How to interpret the score? The higher the score, lower is the risk of complications. That is, higher the score indicates better postoperative condition. Therefore, the score less than or equal to 4 shows high risk of complication, so the patient need to be monitored closely in an ICU setting. And the score of less than or equal to 6 carries moderate risk. Consider close observation since they are at high risk of complication. And the score of more than or equal to 7 is of low risk and consider usual care. The merits using the surgical Apgar score in practice are the surgical Apgar score can help identify patient at high risk of postoperative complications, allowing for early intervention and improved outcomes. It is simple and has been validated across multiple institutions and countries and has strong predictive value for postoperative morbidity. Conclusion: both scores are valuable tools for assessing high-risk patients and perioperative care. PPOSM is a more comprehensive score that takes into account physiological and operative factors, while surgical Apgar score is a simple, more objective measure of postoperative conditions. Thank you.
Thank you, Dr. Shruti. POSM and SAS therefore remind us that postoperative risk isn't random, it's measurable. POSM shows us the patient's baseline strength and the surgical stress they endured, while SAS captures the silent story inside the OR. And so when we use both, we don't just react to complications, we anticipate them. And we plan better, thereby having safe escalation and safer outcomes from scores that we have applied in minutes. In our next episode, we bring it all together. The ASA, the cardiac risk scores, the pulmonary risk scores like the ARISCAT and the stop bang, and the post-op predictors like the POSM and the SAS, all in one integrated framework. And we'll show you how these scores connect, how they complement each other, and how to use them to make clear, confident, perioperative decisions for our patients. So stay tuned for putting it all together in our next episode. See you. Bye.
Good evening. Welcome back to the session of medical communication. Today we are going to learn about how to communicate the bad news. See, many protocols are available and the most popular one is SPIKES protocol, SPIKES, which was published in the year 2000. The SPIKES protocol is a 6-step protocol for delivering bad news. S stands for setting up of conversation, where you are ensuring and arranging privacy. P stands for perception, where you are assessing the patient's current understanding of their medical situation. I stands for invitation, where you are inviting or getting permission from the patient to deliver the bad news. And K stands for knowledge, where you are explaining the diagnosis or you are providing the bad news in clear, easily digestible chunks. And E stands for emotions, where you have to acknowledge emotions as they arise. And S, the last step is strategy and summary, where you plan and summarize the main parts of consultation. So always be prepared. Your position, your posture are very important. Simply placing your feet flat on the floor with your ankles together and putting your hands palms downward on your lap is a successful neutral position. Moreover, maintaining eye contact with your patient will help ensure your attentiveness. So this is an ideal position. You can see the doctor is keeping the feet down, ankles together, arms and hands down on the lap, and he's maintaining the eye contact. Now let us discuss in details all the steps. Yes, meaning setting up the conversation. Right time and right place. You have to select an appropriate area, a warm area, quiet area, which should be a welcoming one for uninterrupted conversation. There should not be any disturbances. Prepare yourself. You have to study the case. You have to review the case. Keep all the documents ready on your table. You should anticipate different questions, can anticipate reactions, and you should prepare your message in clear and precise manner. No beating around the bush. And involve the team also. You can involve other doctors, the nurses, social workers, and psychologists in the discussion. And during this setting up the conversation phase, you can build a rapport and can be empathetic. The second step is perception, where you are assessing the patient's current knowledge about the medical issue. You are trying to find out how much patient knows about the problem. And also, you are trying to understand the seriousness of their condition. Are they aware about the condition? And are they aware about the seriousness of the condition? And in this step, you listen more than you talk. And there is no need to challenge the patient about the hopes. The patient is trying to, repeatedly talk about hopes. Never challenge the hopes. Now, invitation, you're getting permission to have the discussion. Ask before you tell. You can ask the patient, can I tell you your issues, your medical issues? And ask if they want to know the details of disease and treatment, how much they want to know. Okay. And if they are not ready, don't force them. You can postpone the meeting and you can wait for the permission. So invitation is a very important step where you are actually getting permission for discussion to proceed. And in this step, you can use something called warning shots. I tell you examples. Unfortunately, I have some bad news to tell you. Because before you deliver the bad news, you can use this warning shot. Or you can say, I'm sorry to tell you that. Okay. Or things are not going in the direction we had hoped. നമ്മൾ വിചാരിച്ചതുപോലെ അല്ല കാര്യങ്ങൾ. ഞാൻ പറയാൻ പോകുന്ന അത്രയ്ക്കൊരു നല്ല കാര്യമല്ല. Okay, these are the examples of warning shots. And then comes knowledge, K. Here you are explaining the facts to the patient. So this is the phase during which the bad news is delivered. So you have to explain. That is a very important thing. And always avoid medical jargon. Always use simple language. Instead of telling there is an opacity in the middle lobe of your lung, you can say there is a swelling in your lung. That's what is seen in CT scan. And you have to give the information in small chunks because the information should be digestible for them. Okay. So always give it in small chunks. And during delivery of bad news, you have to look for the response from the patient, emotional response from the patient. Okay. And always be clear, be factual. Sometimes you need to repeat what you said and be empathetic also and offer hope. How to offer hope? Suppose it is a metastatic issue. Okay, you can measure disease. You can say, even though the disease has spread, we can take care of your symptoms. Okay. Suppose it is you are explaining anesthetic risk. Okay. You can say, there is a risk. There is an increased risk because compared with a normal patient, you are having higher risk during anesthesia and surgery, but we will take care of you. So in this way, you can provide, you can offer. And then comes emotions. Emotional outbursts are expected. You can acknowledge and validate their feelings. It can be sadness, it can be anger, it can be fear. And here comes the importance of therapeutic touch. The last session I told you about the proper use of therapeutic touch. And also your response should be an empathetic one and you should be supportive also. Always anticipate the emotional responses because they may range from simple silence or it can be dramatic crying or even sobbing. So this is something which you should anticipate. Okay. And then comes strategy and summary. Here you are discussing with the patient about the treatment plans. In the case of a pre-anesthetic checkup scenario, you will be telling about the management. Okay, intra-operative and post-operative management. Okay, you can discuss about the benefits of the treatment. You can discuss about the risks involved. You can discuss about the expected outcome. Okay. And always ensure that he or she understands the information that has been provided. So you have to ask the patient, what do you understand? So I told you many things about your problem. So what is your perception? What do you understand? Okay, that is very important. Never assume that patient has understood everything which you have told. And it is important to ask your patient if they are ready for such a discussion. Okay. That is also very important. Earlier, I told you about invitation before you delivered the bad news. When you plan for discussion about the treatment, you have to ask your patient if they are ready for such a discussion. And you can plan for further care. Examples are referral, supportive care, and so on. And you can close the interview. Now, how to close the interview? This is also important. Okay, this particular statement is a useful one. Would you like to ask me anything more? ഇനി എന്തെങ്കിലും എന്നോട് ചോദിക്കാനുണ്ടെങ്കിൽ ചോദിച്ചോളൂ. So you are actually permitting the patient to ask more. Okay. Because most of the times, patients are afraid of doctors, isn't it? If you tell like this, they will be more, they will open more. So to sum up, Spike's protocol is the most commonly used protocol for communicating the bad news, where S stands for setting up a conversation where you are ensuring privacy. P stands for perception, where you are assessing how much the patient knows about the problem. And invitation is getting permission from the patient to deliver the bad news. And K, knowledge, is the phase during which you are delivering the fact. You are delivering the bad news to the patient in small digestible chunks. And whenever you are delivering the bad news, always look for the emotional reaction of the patient. And E is the emotions. You have to anticipate emotions. You have to empathize with the patient. You have to validate their emotions. And S is the last phase that is strategy and summary, during which you are enforcing the plan and summarizing the main parts of consultation. So thank you, ASA Kerala, for giving me this opportunity. So next session, that's the 5th session, we are going to learn about do's and don'ts in medical communication. Thank you.
Good evening, my dear friends. Welcome back to another episode of Blockbuster. Here we try to debunk the myths related to peripheral nerve blocks. Today in this episode, we try to debunk another myth, that is, deep sedation is necessary for patient comfort during nerve blocks. But the reality is, most peripheral nerve blocks can be performed comfortably with minimal or no sedation and appropriate techniques. Let us quickly discuss the anatomy of a peripheral nerve. The peripheral nervous system comprises 3 types of cells. That's a neuronal, glial, and stromal. Neuronal cells or peripheral nerves convey the signals between the spinal cord and the body. The glial cells such as Schwann cells myelinate the nerves, and stromal cells such as the endoneurial fibroblasts provide the structural support. The structural support by the connective tissue in 3 layers, that is endoneurium that connects the axon, and the perineurium that connects the fascicles. The axons unite to form the fascicles there, and the fascicles unite to form the nerve that is connected by the epineurium. And regarding the peripheral nerve injury in regional anesthesia, mainly the mechanical injury due to the injection, ischemia, insult, and neurotoxic. The mechanical injury or the needle trauma affecting the perineurium can negate the protection environment of the fascicles, increasing the risk of peripheral nerve injury. Injection of local anesthetic to a denuded axon can cause acute inflammatory reaction or neurotoxicity. Injection can also transiently increase the intraneural pressure, leading to ischemia. Bleeding around the nerve also can happen, and other non-specific inflammatory response can set in, resulting in neurotoxic damage to the nerve. If the fascicle is penetrated, neurons are exposed to local anesthetic that can cause a time and concentration dependent injury. If you are using the vasoconstrictors, that will limit the local anesthetic clearance and thereby enhancing the time dependent component of the injury. Decreased neural blood flow due to edema or mass effect can also precipitate the cytotoxic injury, and altogether is a combination of different type of insults. And this is a nerve injury classification chart. The Sunderland nerve injury classification is established in 1951. Recently, we had a few updates on that, like 6th one is a multiple level injury and all. But anyway, the first one is a neuropraxia. Here the myelin sheath is affected, the axon is intact, and recovery wise it's complete and rapid recovery within days or weeks. No repair or surgical repair is needed. Second, grade 2 is an axonotomesis. First one is a neuropraxia alone, but second one is axonotomesis. Axon is injured, endoneurium is intact. Here also the recovery is a good recovery without any surgical intervention. Injury of the peripheral nerve injury after our nerve blocks is mainly of the first 1 or 2 grades. And if you are deep sedated patient, if you are performing a block on deep sedated patient, there is an increased patient acceptance and comfort, of course. And that avoid unexpected patient movements and aberrant needle placement. And of course, the pediatric patients, we need to sedate them. And local anesthetic systemic toxicity is rare with ultrasound guided, even if your patient is deep sedated. And the last important thing is an operator comfort is very much with the deep sedated one. Ultrasound guided techniques can visualize the nerve and confirm the drug spread also, and avoid the vascular puncture and low volume and low concentration. We can, that is a low volume and concentration we can reduce with the ultrasound. And another, but there is a caveat there. The current ultrasound technology does not have an adequate resolution to distinguish between the intervesicular and intravesicular injection. This point is be very clear that at any cost we have to avoid the intervesicular injections. The intravesicular injection has to be avoided, but intervesicular injections to some extent we can allow. The patient comfort, patient satisfaction is driven by the anxiolysis, that is the reduction of fear, and pain control by local and subcutaneous infiltration, and not by unconsciousness. Patient can use patient as a monitor for paresthesia, pain on injection, and earlier signs of local anesthetic systemic toxicity like circumoral numbness, tingling sensation, metallic taste, and lightheadedness all. Before the neurological and cardiovascular collapse occurs. And multimodal anxiolysis is the answer. The pharmacological one is a midazolam, we can give it. And psychologically, the real-time reassurance, that is very important. You have to explain it very well to the patient. And throughout the procedure, you have to communicate with the patient regarding the each and every step. What I personally do is that I will show the monitor to the patient, and these are the nerves and these are the arteries. This is my needle is going around there. In an educated patient, they are well accepted there. But some patients say that, doctor, I don't want to see all these things. The procedural wise is a meticulous local anesthesia. That is the local anesthesia of skin and subcutaneous tissue. These are the area where the maximum pain occurs. And technology by latest wise, the virtual reality headsets we can distract the patient from that. Okay, minimal anxiolysis is highly recommended there. And this is a second ASRA practice advisory on 2015. And latest newsletter on 2024 is on the nerve blocks under general anesthesia, safety versus benefits, and these are the conclusions there. Consider the patient alertness as a possible safety mechanism to complement ultrasonography, opening, injection pressure monitoring, and peripheral nerve stimulation. Remember, ultrasonography and injection pressure monitoring and peripheral nerve stimulations are highly recommended. And duty of anesthesiologist is to perform a nerve block in awake or mildly sedation patient most of the times. Of course, we have to sedate in selected patients. Early and subjective central nervous system manifestation of the last is undetectable in anesthetized patients. And of course, the last is the risk-benefit analysis has to be done on individual case basis. And to conclude the clinical pearls, the post-block peripheral nerve injury are rare. As we have already discussed about the things, most of them are neuropraxic and short-lived and good prognosis. Around 1 to 2% last for 3 months, around 1 year, around 0.05% will only last for 1 year. And we should be careful on the nerve injury part, that is a nerve trauma or the existing trauma. You should be very careful. And patient positioning, tourniquet, and surgical mechanics, all this can produce nerve damages, and existing neurological problems has to be careful. And tourniquet and all, if there is a return of nerve function within 6 hours, if the ischemia time is less than 2 hours. Post-surgical, there is an entity that's a post-surgical inflammatory neuropathy, that is immune-mediated one, whether it's a regional anesthesia or general anesthesia, no difference. And the last and very important thing is informed consent. Document the existing neurological damage, especially in trauma and all. Patient may have proximal humor, the mid shaft humerus fracture there. They may have a spiral groove and a radial nerve injury may be there. If you perform a brachial plexus block without documenting it, you may be blamed on the regional anesthesia technique. Our block will be blamed on that. So you should document all the check and document all the neurological deficit there, and of course the conditions, pre-existing conditions, whether it's a metabolic or neurological or a vascular condition of the patient, that is we call it as a neural health of the patient there, diabetic and all other neuropathy and all. You have to document, and you have to discuss the possible outcome with the patient and its caregivers about these conditions, and there is a possibility of nerve damage and all other things there have to be discussed. And of course in condition like multiple sclerosis or amyotrophic lateral sclerosis like conditions, maybe sometimes it may be, even though it may worsen, the neurologic condition may worsen after the anesthesia, whether it's a regional or general anesthesia, the possibility of worsening the neurological conditions, that has to be explained, and weigh the merits and demerits and discuss the patient and sign the consent there. And last very important thing is avoid intravesicular injection at any cost. You should use ultrasound. Peripheral nerve stimulator is needed, especially in deeper blocks, and the stimulation has to be more than 0.4 milliamperes. If less than that, that means they are inside the nerve. And injection pressure monitors are there, but routinely we are not using it. But still, even especially in a sedated patients, you should be aware of the injection pressure, and of course pain on injection if patient is awake. Some of my references. And deeply sedated patient is a satisfied patient. It's more of an operator anxiety. So the misconception, all patients require deep sedation or general anesthesia for peripheral nerve block, is a myth. The reality is most peripheral nerve blocks can be performed comfortably with minimal or no sedation using appropriate technique and patient preparation. So my dear friends, you decide. Is it safe to silence the alarm of your most sensitive perioperative monitor, that is patient? See you next week with another interesting myth related to the peripheral nerve blocks. Until then, my dear friends, goodbye.
Imagine a drug that you use on a daily basis to put your patients to sleep, incapacitate a theater full of unsuspecting individuals. Imagine chemical compounds being prepared in laboratories that end up in the wrong hands of spies, assassins, and even desperate governments. This episode follows a timeline through Cold War experiments, incapacitating agents, a theater siege, and high-profile poisonings that shocked the world. Tonight, we explore what happens when anesthesia drugs cross the line from operation theater tools to weapons of war and instruments of espionage. I'm Devi Padmakumar, and welcome back to episode 4 of the Anesthesia Chronicles, where we discuss stories that truly matter from all walks of anesthesia. Before anesthetic agents drifted into war strategies and intelligence files, the idea of using chemicals to control human behavior had already captured the imagination of military generals and spies. Let's rewind back to World War I, when chemical warfare first appeared on a mass scale. Although the gases used then, the chlorine, phosgene, and mustard, were not anesthetic agents per se, they opened the door to a chilling realization that chemistry could shape battlefield without bullets. So by the 1930s and 40s, scientists were isolating and synthesizing new class of sedatives and psychoactive compounds. So this period coincided with the birth of modern anesthetic agents, such as thiopentone in 1934, the earliest barbiturate anesthetic. So during the Second World War, both Allied and Axis intelligence services toyed with chemical drugs in interrogations, hoping that these chemicals might extract valuable information or break resistance. So these were crude methods, nothing systematic, but enough to spark post-war interest among intelligence services. Then came the Cold War, the golden age of scientific ambition and paranoia. Two superpowers racing for dominance in rockets, nuclear physics, and discreetly in mind control. In the United States, this obsession crystallized in a now infamous umbrella of programs, the most notorious being the MK Ultra. Beginning in the early 1950s, the CIA secretly funded experiments on hypnosis, sensory deprivation, psychedelic drugs, and nearly any chemical thought to influence consciousness. LSD became the headline agent, but it wasn't the only compound of interest. Barbiturates, amphetamines, scopolamine, and other sedative hypnotics were tested in combinations. Many of these experiments were unethical, unregulated, and without the consent of participants. The MK Ultra left a legacy of secrecy and psychological trauma. Meanwhile, military researchers on both sides of the Iron Curtain were contemplating a new category of weapon, chemicals designed not to kill but to disable. A battlefield where soldiers suddenly became confused, disoriented, and unable to fight. So this gave rise to what defense circles called as incapacitants. The Soviet scientists too similarly investigated the use of fentanyl and its analogs as potential tools for covert operations or crowd control. So these efforts remained shrouded in secrecy, but decades later, their fingerprints were evident in real events. By the late 20th century, the world realized that it needed to form rules. The Chemical Weapons Convention of 1993 took a bold step banning the development and use of toxic chemicals for warfare. However, there was a gray zone, the use of certain agents for law enforcement, a term that was left intentionally vague. So this loophole would later prove pivotal and controversial in the 21st century. By the turn of the new millennium, militaries had researched sedative or delirium-inducing compounds as tactical tools. As mentioned previously, international law had banned certain agents but left room for interpretation. All it would take was one dramatic event to bring this hidden world into public view, an incident that would shock toxicologists, anesthesiologists, and policymakers alike. On the evening of October 23, 2002, Moscow's Dubrovka Theatre was packed for the popular musical Nord-Ost. Families, students, office workers, more than 800 people filled the seats. Just after 9 p.m., the normal hum of the auditorium was shattered as 40 heavily armed Chechen militants surged onto the stage. For the next 57 hours, the theatre was sealed. Outside, special units, counter-terrorism officials, and medical teams formed the perimeter. Several hostages later recalled that the militants wired the halls with explosives and threatened massive detonation if the Russian forces attempted a rescue. As negotiations dragged on, the Russian authorities made a controversial decision, one that would forever link anesthetic pharmacology to modern counter-terrorism operations. They prepared to deploy an aerosolized incapacitating agent through the building's ventilation system, a compound intended to rapidly sedate both militants and hostages, allowing special forces time to storm into the theater. For nearly a decade, the Russian government did not reveal the true identity of the compound used. At that time, the officials simply referred to it as a non-lethal gas. Early in the morning of October 26th, eyewitnesses outside saw a faint mist seeping through the ventilation grills. Inside the auditorium, hostages reported a sweet chemical odor. Some felt sudden dizziness. Others became unconscious within minutes. The Russian forces then stormed into the theater. The militants inside, overcome by the gas, were unable to resist, but so were the hostages. So after that event, hundreds of unconscious civilians were being taken to the hospital. The emergency teams faced a nightmare scenario. Mass casualties, all presenting with respiratory depression and death. The medical personnel had no information on what agent had been used. As many Russian doctors later described, they were treating patients they didn't know how to treat. So in the end, at least 125 of the hostages died, not from gunfire, but from the effect of the chemical agent. Years later, independent toxicologists analyzed clothing, biological samples, and personal items from survivors and the deceased. The findings were striking. They found traces of carfentanil and remifentanil used in the aerosolized form. The evidence strongly suggested that the aerosol was an ultra-potent opioid mixture likely dissolved in a volatile organic solvent to facilitate dispersion. Why opioids? From a tactical perspective, opioids cause rapid sedation, immobility, and reduced capacity to fight within seconds to minutes. Unlike nerve agents, they do not cause seizures or overt signs of chemical warfare, and they allow a nearly silent form of incapacitation. But as the margin between sedated and fatal respiratory depression was thin, the result was catastrophic. To this day, the full operational details remain classified. The Russian authorities maintained that the use of the agent saved far more lives than it had claimed. Many medical and human rights groups, however, argue that withholding the identity of the agent from treating physicians was a fatal error. So, what is carfentanil? A compound that sits at the extreme edge of opioid pharmacology. Carfentanil was first synthesized in the 1970s by scientists exploring new ultra-potent opioids. It belongs to the fentanyl analog family, drugs that bind strongly to opioid receptors, producing profound analgesia and sedation. In today's medicine, fentanyl itself is potent, but carfentanil, it has a league of its own. Carfentanil is estimated to be approximately 10,000 times more potent than morphine and 100 times more potent than fentanyl. It was never created for humans. Instead, it was developed for large animal immobilization, such as elephants, rhinoceroses, large mammals, where rapid deep sedation is required and small doses can be controlled with precision by specialized teams. So for treating physicians and toxicologists, carfentanil can be a nightmare scenario. Its potency means that even a small dose can cause fatal respiratory arrest. So in the years following the Moscow siege, what made the experts even more concerned was that carfentanil began appearing sporadically among illicit drug markets all across North America, Europe, and parts of Asia, often mixed with heroin or other psychoactive substances. And the consequences were catastrophic. As the world began to understand how dangerous carfentanil could be, international authorities moved to tighten control around its manufacture, distribution, and research. The first major step came in 2017 when the United Nations Commission on Narcotic Drugs voted to place carfentanil under Schedule 1 of the 1961 Single Convention on Narcotic Drugs. This is the UN's highest level of restriction, reserved for substances with extremely limited or no medical indication in humans, and with a high potential for harm. Agencies such as the International Narcotics Control Board and the World Health Organization now monitor fentanyl analogs closely. Anesthetic drugs save lives every day, but history shows that they can be twisted into agents of harm, from secret programs to public poisonings. Awareness, ethics, good medicine, a strong forensic support, and international norms remain our best protection. If this episode raised questions for you, clinical or ethical, tell us which aspects you would like us to expand in the future episodes. So until we meet in our next episode with a new story, good night and safe practice.
Good evening, everyone. Thank you, Dr. Devi Prasad, for that wonderful insights on Anesthesia Chronicles. Myself, Dr. Parvati from Sri Chitra Tirunal Institute for Medical Sciences and Technology. So now we move on to the much awaited ISA Kerala Kahoot quiz. All of you can join the quiz using the game pin flashing on your screen. That is 4764342. So please, for the first prize winner for last week's quiz is Dr. Guru Sandhya Shravan Perumal. Got a cash prize of 1,000 rupees. She is from Kumaran Medical Center, Coimbatore, and a certificate of appreciation for Dr. Guru Sandhya Shravan Perumal. Coming to the first runner-up, Dr. Nila A.V. from Trivandrum got a certificate of appreciation. And second runner-up is Dr. Shruti R.S. from Trivandrum. She also got a certificate of appreciation. Congratulations to all our winners. We'll wait for some time for others to join the quiz. So please listen carefully for the rules. You can join the Kahoot using Kahoot app or from website because there is a slight time lag. And the nickname format is first 4 alphabets of your name and your phone number. It is strict that those who are not following will be unfortunately disqualified. You will get 30 seconds for each question. Speed and accuracy matters. The faster and the accurate you answer, the more you score. So winners will get, first prize winner will get a cash prize and an e-certificate, and second and third prize winners will get e-certificate of appreciation. So let's see who all paid attention to last week's class. So let's start today's quiz. I hope all of you have joined using the Kahoot pin, that is 4764342. Coming to the first question, which ARISCAT score cutoff predicts the higher risk for developing post-operative pulmonary complications? Option A, more than or equal to 25. Option B, more than or equal to 35. Option C, more than or equal to 45. And option D, more than or equal to 55. Eleven of you have answered. So coming to the answer, 7 of you have answered the correct answer. Coming to the next question, let's first see the scoreboard. Guru scores first. Coming to the second question, the distance typically maintained during professional medical interaction is option A, 0 to 0.45 meter, option B, 0.45 meter to 1.2 meter, option C, 1.2 meter to 3.6 meter, option D, 3.7 meter to 4.5 meter. The distance typically maintained during professional medical interaction is ten of you have answered option B, but the correct answer is option C. Coming to the scoreboard. So next question. Which of the following is a recognized limitation of ultrasound guidance in nerve blocks? First option, it has no use in pediatric anesthesia. Second, visualization of deep structures may be poor, especially in obese patients. Third option, it always provides continuous perfect visualization of needle tip. Fourth is inability to find bony landmarks. Let's see who is climbing up the leaderboard. Remember, the faster you answer, the more you score. 11 of you have answered correctly. Let's see the scoreboard. Guru has climbed up the leaderboard. Second is Neela and third is Ruth. Please get ready for the next question. The AWARE-2 trial primarily investigated. First option, BIS value during deep anesthesia. Second option, long-term cognitive decline after ischemic stroke. Third option, dream recall after sedation. And fourth option, consciousness and awareness during CPR in a cardiac arrest patient. Nine of you have answered correctly. Let's see the scoreboard. Shruth has climbed up the scoreboard. Second is Sun and third is Priya. Going to the next question. Which anesthetic condition most increases the likelihood of near-death experience, NDE-like experience? First option, by inducing breath suppression, EEG by thiopental. Second option, ketamine dissociation with preserved cortical activity. Third option, deep propofol anesthesia combined with neuromuscular blockade. And fourth option is obtaining bispectral index 40 to 60 with sevoflurane and multimodal opioid analgesia. Correct answer is ketamine dissociation with preserved cortical activity. So coming up next week, we have the case presentation on diabetes and anesthesia and a journal club presentation. So the link for the article is given in the description box below. Please everyone have a look. Diabetic case presentation, diabetes and anesthesia case presentation, which will be moderated by Dr. Gopakumar D, Senior Consultant, Department of Anesthesia, Anantapuri Hospital and Research Institute, along with Dr. Bharati Vatwa, Director and Professor, Department of Anesthesia, Maulana Azad Medical College, New Delhi. And the presenter will be Dr. Shruti R.S. Next, coming to the journal club presentation, which will be moderated by Dr. Lakshmi Kumar, Professor and Head, Department of Anesthesiology and Critical Care, Amrita Hospital, Kochi. And the presenters will be Dr. Maharnap Bhoyan and Dr. Nalluri Achyuta Krishnasri. Find the link for the journal club below from the description. This is the original article, Thoracic Spinal Anesthesia, an effective alternative to general anesthesia in breast surgeries, a randomized, non-blinded study. So everyone please download and have a look ahead. Now we will display the final results. Coming to the podium, third prize is by Sun, scoring 3,030. Second is by Priya, and first is by Shruti. Congratulations to all the winners. Your prizes will be sent to you very shortly. Thank you again. Thank you everyone for joining this week's ISA Kahoot quiz. I hope to see you next week also. I thank ISA Kerala Connect for giving me this opportunity to conduct today's quiz. Now we will proceed to vote of thanks. I request Dr. Arjun to take over. Thank you all. Have a nice day.
Thank you, Dr. Parvati, for that engaging session. You have conducted this session without losing interest, and it was quite engaging in a way. Thank you, Dr. Parvati, for that absolutely well-crafted quiz.
Thank you, sir.
I also thank all the panelists for today who have shared their knowledge about various things. I thank Dr. Shruti Esterin Koshi from Believers Church, who illuminated us about the risk scores in anesthesia. And thanks to Dr. Baburatsi from Thrissur, who has always tried to instill that importance of communication for us. And I also thank Dr. Sajeev sir for that blockbuster and dispelling the myths of blocks. And I also thank Dr. Devi Padmakumar for her very excellent Anesthesia Chronicle, which is as interesting as always. So, and I once again thank Dr. Parvati for conducting this quiz. So, as a part of ISA Kerala chapter, I thank everybody of our participants for their active participation in this ISA Connect, and also for the participating in the ISA Kerala Kahoot quiz. We will locate the participants winners by their nicknames, and we'll announce the full nicknames of the full names of their winners in the next week. So thank you everyone for your active participation. Thank you.